Welcome to the Ashraf Garda Show. Professor Shabir Madhi, the Wits Professor of Vaccinology, thank you for your time. Welcome to what we call the agenda setter here on the Ashraf Garda Show.
Thank you for having me, Ashraf.
Now, talking about agenda setting, from a South African perspective, perhaps nothing more significant under the broader scheme of COVID-19 than the beginning of vaccine testing in South Africa, which you very much a part of. So tell me what has happened.
Right now is that we've entered into some sort of a collaboration with the University of Oxford, who are essentially providing us with a Agenda Institute against COVID-19. And the technology that was used to develop this vaccine is very similar to the technology which was used to develop a vaccine against SARS and the MERS corona. Oxford group basically initiated the study on the same vaccine in the United Kingdom since the beginning of April. And they're planning on enrolling 10,000 participants, and they've already enrolled 7,000 participants. So when we got wind of this vaccine that was being developed at University of Oxford, and because of some scientific relationships that I've got with one of the key investigators there, we started to embark on this journey to see if it would be possible to bring this vaccine to South Africa and have it evaluated in a South African context. And that is especially important because when it comes to vaccines, what we know about vaccines is that many vaccines perform very differently in high-income settings compared to low-middle-income settings. Vaccines that might be highly efficacious in one setting might not necessarily be efficacious or might be less efficacious in a different setting. And obviously our populations are very different as well. So we really need to be able to understand how well the vaccine works in our own context with our own population demographics to be able to determine what the public health value of this vaccine will be moving forward. So we've been fortunate enough in terms of being able to successfully vaccinate the first individuals in the study that is being conducted in South Africa, which is completely separate from the Oxford study, and where we plan to enroll up to 2,000 volunteers over the period of the next 5 to 6 weeks.
Okay, and I understand that you've now started the testing. So here's the thought. I mean, somebody met me this morning, and his immediate thought to me was like, so I see these guys from Wits have started some vaccine thing, so everything is going to be okay. So I thought I'll convey that message to you. I mean, how close to the reality is that statement?
Yeah, so I think we need to understand that when it comes to vaccine development, the success rate for vaccines is roughly about 10%. So 1 out of every 10 vaccines that go into human studies, and this is not even looking at vaccines that don't reach human studies, almost 1 out of every 10 vaccines actually fail. And a good example of that is HIV, where we've been in a search for a vaccine, singularly unsuccessful in terms of developing an HIV vaccine. Fortunately, the SARS coronavirus is much less complex than an HIV virus. So the prospects of developing a vaccine looks much brighter. But at the same time, right now, there's about 200 groups that are trying to develop a vaccine against COVID-19, right? And that's probably unparalleled in terms of the number of people that are working on trying to establish a vaccine. We would be extremely fortunate, and we would have done really well if in a period of the next 2 years, we can at least get 5 of those vaccines to be registered. The majority of those 200 vaccines are simply not even going to go into human studies, let alone shown to be safe and effective in humans in terms of protecting against COVID-19. The vaccine that we basically involved with, this vaccine is furthest in a development pathway when it comes to human studies. So the other vaccines are sort of still more in what we call phase 1 studies, which means that they're looking at a correct dose or trying to establish initial safety profiles or how immunogenic the vaccines are. The vaccine that we're looking at basically has gone through phase 1 studies. It's now in phase 2 studies, which is what we're currently doing, which now gives us option of the ability to be able to get a readout. In addition to the safety, expanding the safety profile, it also provides an opportunity to get a readout in terms of whether the vaccine actually protects against one developing COVID-19. In a best case scenario in South Africa, we might get an answer by the end of this year. That's the best case scenario. If not, we probably have to wait till around about June of next year to get an answer. It really depends on how the virus continues transmitting in South Africa, which will influence how quickly people get infected and how soon we will be able to get an answer from our study. In the United Kingdom, they also expect to get an answer sometime this year. But once we even show that a vaccine, if we do show, and are fortunate enough to show that a vaccine actually protects against COVID-19, that in fact is just the start of another long journey in terms of getting the vaccine licensed by regulatory authorities, and then for companies to start manufacturing the vaccine at scale. So it's unlikely, even under the most optimistic scenario, that there would be a vaccine that would become available on the market before the middle of next year. And even if a vaccine becomes available on the market by the middle of next year, the reality is that there's no company that's going to be able to produce close on to 6 billion doses of vaccine, which is probably what we require globally to get a sufficient proportion of the population develop immunity. So we're still a far way off, but this remains our best opportunity in terms of breaking the back of the pandemic.
Let me therefore then understand this. There was a sense when I'd heard about the vaccine testing rollout from Wits University, specifically a sense of almost euphoria for people who think that it's already been tested and proven, but maybe that's far-fetched, we know that. But also the fact that we're doing it. What I'd like to just find out from you is, like, is this euphoria based upon the fact that we can test? So is that the victory at this point, that we can test? Or is the sense of expectation so great that many people believe that it's a done deal? So what I'm trying to get at is there a sense of achievement already from people like yourself in terms of what you're starting to test, or is it very, very premature that we're even talking about what your department has achieved?
Yeah. So there certainly is a sense of achievement, and we should be proud in terms of what we've been able to do in South Africa over a very short of period of time. We need to understand there's a huge amount to get involved in this sort of vaccine studies, a huge amount of competition. The reason why we were successful in being able to attract this opportunity to South Africa is really because of the legacy of the scientists in South Africa in terms of development of vaccines in the past. The clinical development. My own research unit, as an example, has been the first unit in the whole of Africa and the whole of the Southern Hemisphere, in fact, where we evaluated vaccines against pneumonia and tidal disease, which are the pneumococcal conjugate and rotavirus vaccines, which are life-saving vaccines. So that has placed us in a position to be very competitive in terms of attracting interest from different individuals that are keen to evaluate the clinical development of the vaccines, but also has allowed us to be highly competitive in terms of getting funding to be able to do this sort of studies. So that is the accomplishment part. But in terms of the euphoria, as you correctly point out, I think the reality that we face is that in these dark times, any sort of indication of some light in that dark tunnel always sort of increases some sense of, lends itself to euphoria. So, and I think that's where we are, that things look bleak, and anything that shows a vague possibility of making a change or having a positive outcome is going to create excitement. Am I excited about a vaccine? Certainly I'm excited, or else we wouldn't be doing this sort of work. If I didn't think the vaccine had some potential to work, we certainly wouldn't be embarking on this vaccine. There's a number of other companies that are interested in doing studies in South Africa, and we would go with another company, essentially. But the things about this particular study that we're undertaking, firstly and foremost, is that it's really being done as a partnership with an academic institution and independent of any pharmaceutical company. So we are under no obligation to try to paint to have a positive spin in terms of the results that come out of this. We're doing it to look at it from a scientific perspective as to whether it works or not. We're going, like I said, like I've just mentioned, it doesn't mean that we're going to, right? And there's no guarantee of success. There's no guarantee that this vaccine is going to work in protecting people against COVID-19. And even if it works, we don't know whether it's going to provide 50% protection or 60% protection. And it might be that a few months later, there's another vaccine that's evaluated elsewhere that has 90% protection. But the reality, again, at the end of the day, is that there's no single manufacturing facility that is going to be able to produce close onto 1 billion doses of vaccine, let alone 6 billion doses of vaccine. So we require multiple groups to be successful in terms of their endeavor to develop a vaccine. So we got multiple opportunities and platforms where vaccines can be provided, not just to people in the United States or in Europe, but can be widely disseminated throughout the world.
Well, I mean, I gather, therefore, that the stakes are high. The stakes are high in terms of perfecting the vaccine because it will save lives, and I think that's a given. But the other point you made from a scientific point of view, the stakes are high in terms of naturally being pioneers. Okay, but the third of the bigger pictures is the commercial interest. So, to what extent are the companies, and in this case your research unit is not one of the companies, you haven't yet commercialized it, to what extent are their interests to be first past the post, but then to eliminate the opposition, although the cause ultimately will benefit humanity?
So I think in terms of the opposition part of it, I don't think there's going to be any elimination of opposition with COVID-19 because, like I said, there's simply no company that's going to set up a manufacturing facility to produce 6 billion doses of vaccine for the next 2 years. And after that, the requirement will only be a few 100,000 doses. So from an economic perspective, it simply doesn't make sense for a company to do that sort of investment. So there's going to be companies to go forward with a licensure of a vaccine, and I don't think one company is going to try to kill off another in terms of its program. So I'm less concerned about that for this vaccine. For other vaccines, certainly companies develop a duopoly or a monopoly on a vaccine and effectively minimize competition, which is a problem. Now, in terms of the COVID-19 vaccine, there's a number of initiatives, and there's also buy-in from many of the companies that companies are designed to make money. That's the bottom line. But there's a recognition that we're living under different times, and that at least during this period of the pandemic, that a vaccine needs to be made available at a price that is affordable and is close to the cost of goods, rather than any significant margin being built into that price. So that many of the companies are actually being funded by other groups such as what is known as CEPI, or even the Bill and Melinda Gates Foundation, where they're putting investment in terms of the clinical development of the vaccine, so that when it is licensed, part of the conditions for that licensure is that over a certain period of time, it will be made, there'll be sort of a price tiering system, which would allow low-income countries, middle-income countries, either to have the vaccine procured on their behalf or for them to be able to buy it at an affordable price. After the pandemic has passed, certainly we probably will see a hike in terms of the price of this vaccine. This vaccine is not going to, it's going to be required moving on. COVID-19 is not going to disappear in 2020 or 2021. The pandemic might subside, but the reality is that this virus is unlikely to be eliminated from the human population anytime soon. And our only opportunity probably, to be able to actually eliminate the virus would be a vaccine. So people, especially people at that high risk of developing severe disease, they're going to probably continue requiring a vaccine beyond 2022 if the pandemic has subsided by then. So there's still going to be a market at that point. But in the immediate future, I think most companies simply accept that they're not going to be making much money out of this. They might make some money just because of the sheer volume, but there's going to be social consciousness in terms of the pricing of these vaccines.
So for where you sit then, as the Vice Professor of Vaccinology, then give us an insight into your day-to-day workings, specifically around COVID-19, meaning what do you and your team do? What have you been doing on a day-to-day basis?
Yeah, so this research unit has been running for about 24 years, and without reservation, I can say that we've never been as busy as we've been for the past 3.5 months. So certainly once the first COVID-19 was identified in South Africa, and clearly from what I could see was happening in the rest of the world, especially at that stage, mainly in China, in Wuhan, it was clear that this was unfortunately the pandemic which scientists have been warning about for the past 20 to 25 years. So as a scientist, especially for someone that's involved in the field of respiratory pathogens, coming across this pandemic, unfortunately, we were probably overdue in terms of an outbreak of a pandemic of this magnitude. So it didn't come too much as a surprise. It's something that we would rather not need to deal with, but it is upon us now. So what's happened is that we've largely needed to shift our focus. We're still very much involved in vaccines in other fields, but we've needed to shift a huge amount of our resources to focus on COVID-19 at multiple levels. And that includes looking at epidemiology, looking at COVID-19 in relation to pregnancy outcomes, as an example, looking at COVID-19 in relation to healthcare worker infections and how we can try to reduce that. My own unit, as an example, has taken on the responsibility for doing all of the testing for people that actually are admitted to Baragwanath Hospital. And that is something that we're doing at our own cost right now. And it's something which, had we not been doing it, Baragwanath Hospital patients that have been admitted probably would be waiting 5 to 14 days to get a result. We're probably the only public hospital that's been able to give a result within 12 to 24 hours because of the testing that's being done in my research unit. So the staff in the research unit have been magnificent. Rather than working what they signed up to do, which is an 8 to 4 day, 8 hour day from 8 o'clock to 4 o'clock in the afternoon, overnight they've transitioned into accepting that they need to work till 9 o'clock each day. They've got shifts, they work 7 days a week, and there's been a complete change in terms of the sort of DNA of the unit, in a sense, in terms of its work ethic and everything else. It's come at a huge amount of stress, not just to me, but to all of the staff in the unit as well. And I think, like I said, we've been in this for 25 years, and this is the hardest we've ever worked, and it's probably been the most stressful period in the past 25 years.
And how then do you internalize it? Because I'm thinking, on the one hand, there's a great sense of fear around what the pandemic is causing. Certainly many people are. I certainly feel anxiety myself. On the other hand, for people like yourself in the sciences, dealing with research and medicine, this is the opportunity. So it sounds bizarre me putting this to you, but do you welcome the pandemic with a sense of, bring it on, this is what we've been waiting for, this is why we've studied what we've studied all our lives, with excitement? Or is it, we don't want it, but we see our responsibility?
Yeah. I would have much rather lived my life without a pandemic, and without question. And I think most scientists are excited about it, but all scientists probably would much rather have lived their lives without having to experience a pandemic, just purely, not just at an individual level, but in terms of the type of damage it's inflicting in society, on economies, on the health of people. And it's not just the health of people related to COVID-19. And that is something which we still, unfortunately, don't adequately grasp. That the amount of people that will die from non-COVID disease because of the indirect impact of this pandemic probably will far exceed the number of people that will die of COVID-19, especially in low-middle income countries. In high-income countries, they don't have the challenges of TB and HIV and under-immunization of children and all these other vaccine-preventable diseases that can be prevented. But because of the disruption that COVID-19 is causing to the economy, that's causing to society, that's causing to our healthcare facilities, effectively we're working with a double pandemic. The one pandemic is COVID-19 and the other one is a non-COVID-19 pandemic, which is related to our response, which is forced upon us in a sense to COVID-19. So we're going to unfortunately see probably more people die of tuberculosis. We're going to see more people die of HIV, more children die of malnutrition. We're going to see more children die of vaccine-preventable diseases that could have been prevented had COVID-19 not been upon us.
Do you get a sense that outside the vaccine testing, which we'll see what happens in a year's time, that humanity at this point in time we're rather helpless? There's this battle on all fronts, and you've just mentioned it, in terms of health, in terms of economy, in terms of allied illnesses, that by and large, we've been advised and instructed around preventative measures, and that's fine. But overall, in the greater scheme of things, this pandemic has struck, and unless we find a vaccine, we really are sitting ducks one way or the other. Is that a thought that resonates with you?
Without question, unfortunately so, and more so in a country like South Africa. We simply don't understand the magnitude of the problem that's upon us, where the behavior of citizens is simply not aligned as compared to what is actually being demanded of them right now. In South Africa, we've probably overshooting compared to what where we should have been in terms of the pandemic right now. The lockdown had some effect, but it certainly didn't reduce community transmission. And it's also an issue that you can't actually take an experience in one setting, a highly resourced setting, and think that it would work in another setting. So the lockdown had its purpose. That purpose was dealt with. It didn't accomplish all of its objectives. But the bottom line is where we are right now is that the only tools that we've got available to us is basically the populace of South Africa. And it is their adherence to the non-pharmaceutical intervention of mass gatherings, in public spaces, that unfortunately is not happening in the country, in a majority of the population. And that is leading to the type of disaster that we're facing right now. People simply don't understand, for a number of reasons, as to why it's important for every individual to be doing that. The person that's in his 20s and 30s, who's got very little risk of developing severe disease and almost no risk of dying, they are not concerned about wearing a mask because they don't believe to be at risk of developing severe disease, which is correct. But the problem is they are the very individuals that are leading to the increase in terms of the rate of transmission by not wearing the mask, by not adhering to physical distancing, by not avoiding overcrowded situations. And that is putting those individuals at high risk of developing severe disease, at heightened risk of being infected much quicker and over a shorter period of time. So we are really facing dark times in South Africa, and much of that, unfortunately, right now is both because of the virus, but also because of the behavior of South Africans in terms of not adhering to these non-pharmaceutical interventions, which is really unfortunate.
And yet your point about behavior, when I hear in particular the Minister of Health, Zweli Mkhize, and when I hear the President Ramaphosa speaking, outwardly they're very praiseworthy of how South Africans by and large have responded. Do you get a sense that they're just saying the nice things, but they know better, that far too many people are just not adhering to common sense principles around COVID-19?
Yeah, I mean, I think the numbers speak for itself, that when a country such as South Africa reports 6,000 cases per day, which happened yesterday, in the context of actually very limited testing. So we're reporting 6,000 cases per day at a time when our testing rate is probably 6 to 10 times lower than the testing rate in the United States or in the United Kingdom or many European countries. But yet we're reporting 6,000 days. So if we want to, as an example, compare ourselves to the United Kingdom in terms of what happened during the peak of their epidemic, they were testing close on to 8,000 individuals. They were testing at a much higher rate. Right now, they're testing 140 per thousand of the population. We're testing 22 per thousand of the population, as an example. At the peak of the epidemic in the United Kingdom, they were reporting 35,000 cases per week. We already not at the peak of, we're still not at the peak of the epidemic in South Africa, and we're reporting a daily average of 6,000 cases. So we're already overshooting the number of reported cases from the United Kingdom, from Spain, at a peak of the epidemic. So those numbers are only materializing simply because of the behavior of citizens and for no other reason. If people were doing the physical distancing, if they were adhering to, if the majority of people were doing that and adhering to wearing a non-surgical face mask, etc., we wouldn't be where we are right now, and we won't be continuing on this trajectory where there is going to be a disaster in the next few weeks across the country with the increase in terms of transmission. When we talk of 6,000 individuals being infected yesterday, that number probably is an underestimate of at least 5 to 8-fold in terms compared to the true number of people that have been infected. That is just the number of individuals that have been tested that have turned out to be positive. We know that 2 out of every 3 people that are infected with this virus are actually completely asymptomatic. So they wouldn't even know they're infected, and they wouldn't actually present for testing in the first place, but they can still transmit the virus. Most people with mild illness simply are not being tested because of the resource constraints when it comes to testing. So these numbers of 6,000, basically, you probably could multiply that conservatively by 5. And that is the true number of new cases of COVID, of infection that occurred in South Africa
so
yesterday.
You speak about, you use the word, there could be a disaster. So help us understand this. What for you is a disaster, and how long will it take for us to sadly get to that disaster?
Yeah, unfortunately, we're heading to it very rapidly right now. And again, it's got to do with the rate of transmission of the virus. And that rate of transmission is just ongoing rapidly. So when I talk of a disaster, my measure of the start of the disaster is when our healthcare facilities depleted of the where the bed occupancy in healthcare facilities is basically has been maximized, which is pretty much what has been reached in the Eastern Cape, to some extent in the Western Cape as well, which is where we're heading to in Gauteng over the next few weeks. And then it's a matter of using these field hospitals. But the field hospitals are not a solution to the problem, because you can't put a person in a field hospital and not have healthcare workers. And what's happening right now is that healthcare workers are actually getting infected from the virus in the hospitals for a whole lot of reasons as well. So we basically faced with a situation where our traditional healthcare facilities are basically already being overwhelmed and are reaching close to maximum occupancy capacity, in addition to which South Africa has got an endemic shortage of healthcare workers, especially in the private sector, which means that as more healthcare workers need to go off because they've been infected, essentially is going to cripple the healthcare system. Right? And that is what we were trying to avoid, and that's the reason why we went into a lockdown, to give us an opportunity to scale up our facilities. But you don't build healthcare systems over 2 or 3 months or over 2 to 3 weeks. It takes a generation. So there's an important lesson to be learned in terms of underinvestment and the cost of underinvestment, the eventual cost of underinvestment.
I'm thinking in terms of your concern about non-adherence by the public. Is it a case of they're not adhering because they just don't care? They're not adhering because they don't get the grasp of the impact of COVID-19, or they're not adhering because they actually can't, because of South Africa's unique social or socio-economic circumstances. Typically, for many people, how do you convince a person who's battling to find bread to try and outlay some money or to stand in a queue for a mask?
Yeah. So I think the answer is that it's actually a combination of all of those three elements, in that there's sort of dissociation of risk and actually what risk causes. So what I'm saying is an example. What we know about this virus, firstly, is that people under the age of 45 who don't have comorbidity get infected. Very few of them will become symptomatic. The majority, 1 out of 5, is symptomatic. If they do become symptomatic, they're going to have a mild illness. So the person under the age of 45 without comorbidities doesn't really know of anyone else in their social circles that has developed severe illness. So there's a sense of complacency that I don't see anyone getting ill that I know in my age group. So why should I'm not actually at risk, because that's not what I'm experiencing in my daily life. But what they don't understand is yet they're not at risk of severe disease, but they are the ones that are responsible in terms of the transmission of the virus in the community and to those individuals that are at high risk of developing the disease. So even though they don't see the need at an individual level to be able to comply to these sort of non-pharmaceutical interventions or adhere to them, they're inadvertently doing is increasing the susceptibility of other members in the community that are at risk of developing severe disease. So there isn't a complete understanding in terms of the individual risk compared to how the individual actually contributes at a society level in terms of contributing to severe disease and people dying from COVID-19. But as you also correctly mentioned, there are difficulties in terms of adhering to physical distancing, avoiding overcrowded situations. But the bottom line is we need to be pragmatic in terms of how we go about trying to implement what is being recommended. As an example, if you take a taxi, a public taxi, right? There might be 10 people in a taxi, but you can reduce the risk of transmission in that taxi where you can't practice physical distancing, obviously, by wearing a northern surgical face mask of that taxi open. And that would significantly diminish any chance of a person in that taxi being infected by someone that might or might not actually be infected without them actually knowing that they're actually infected. And the same thing goes in any other setting. It's trying to use common sense in terms of what we can do within our resource constraints and within our reality to try to reduce the rate of infection. We are not going to get away from people getting infected. And again, that's another thing people need to grasp. Right? There's no magic bullet that we have, and there never will be a magic bullet that's going to avoid people getting infected. Unfortunately, when this outbreak started and when our initial government response to this outbreak is we were going to beat this virus, right? Which unfortunately was very naive, right? There's no beating a respiratory virus, right? people, that was a really naive approach. And our approach to it, believing that we can possibly go into a level 5 lockdown, and some politicians believe that level 5 lockdown was going to completely eradicate the virus. Again, unfortunately, that wasn't based on any sort of meaningful scientific evidence. So that did serve a particular purpose, but I think people need to understand there's no preventing oneself from getting infected, which is 100%. But what we're aiming for is all about slowing the rate of these are adequately resourced to be able to cope with a number of people that are going to need to be hospitalized. And we would rather have that happen over a longer period of time, draw it out, so that we don't overwhelm the healthcare facilities. If all of those cases, the majority of those admissions, take place as they are currently over a short period of time, that is what leads to the disaster. So people are going to get infected. Unfortunately, many people are going to die from COVID-19. Many people are going to be hospitalized. But our ability to basically respond to that and to be successful in terms of mitigating the full consequences is completely dependent on the rate at which that occurs. So we're wanting to spread it out, at least spread it out, and hopefully we'll get a vaccine before the full consequences of this pandemic
So let
is
me
realized.
personalize this. So let's say, typically you would have a core family of 10 people, some of them much older, grandparents or granduncles, some of them much younger, like toddlers, right? What sort of conversations are you telling this group of 10 people in terms of, we're going to beat we're going to beat the disease? What advice are you telling them? Are you saying that in fact we're all going to get it? What are you saying?
Yeah, we're certainly not going to beat this, this disease. The phase that we, in terms of the phase that we are in South Africa in this pandemic, is probably what phase. And at this phase, which is really a late stage of the pandemic, and unfortunately, that is for this wave of the outbreak. We're probably going to experience another 2 to 3 waves over the period of the next 1 to 2 years. And that's a different discussion. But right in the mitigation phase, which basically means what we need to do is we need to show healthcare facilities are adequately equipped to deal with the influx of patients. But at the individual level, at the household level that you're asking about, what we need to ensure is that those individuals in that household that are at high risk of developing severe disease, they somehow need to be guarded. Right, so having 10 people in a single household is much easier to said than done, especially if you've got a 2-bedroom household as an example. But you need to do everything that's within your means to safeguard those individuals that are at high risk of developing severe disease. So they need to ensure that they maintain the physical distancing even in a household, however naive it might believe, it's sound that you can actually achieve it in a 2-bedroom household. You need to do what is necessary for those individuals to take additional precautions to prevent themselves from getting infected. Things such as wearing in those sort of circumstances, unfortunately, in the household, everyone should be wearing a non-surgical face mask, even in the household. And that's the only way you're going to avoid it spreading in the household. We don't know who is infected and who's not infected. It's too late to wait for someone to be diagnosed in the household before other members in the household, especially those members with underlying medical conditions, start exercising precautions to prevent themselves from being infected, because in all likelihood, they have been infected by the time someone else in that household becomes symptomatic. So we need to, again, just be pragmatic as to what we can accomplish within a household context. People are going to get infected. Up to 2/3 of South Africans will need to get infected until this virus probably starts subsiding. And that is with a proviso that the virus actually induces natural, long-lasting immunity. But at the household level, it's really how we can internalize those sort of non-pharmaceutical interventions within each household.
And at the same time, the call for economic activity. I mean, when we were in lockdown 3 and then it extended, amongst the biggest calls came from the business community about the impact that it's had on their businesses and the impact that it's had, therefore, on people's jobs and therefore livelihoods. Now, that may not be your direct area of expertise, but I mean, within the social sciences, there's a clear connection here. How do you marry then those priorities?
Yeah, I mean, you can never divorce health from the economy. The type of healthcare that we're able to provide is completely dependent on our economy. And having the economy being undermined by our current response to COVID-19, in fact, will have huge healthcare consequences in the next 5 to 10 years, where there's going to be further underinvestment in terms of health. because the treasury is simply not going to be there to be able to fund health. So the two are completely interlinked. You can't separate them out at multiple levels. Again, it all goes to an issue in terms of, is a total lockdown in low middle income countries something that is pragmatic and something that would work as effectively as it does in high income countries? And the short answer to that is we know that the answer to that is no, irrespective of what the WHO wants to say about countries lifting the lockdowns to irrespective of what WHO says. That sort of an approach in a low middle income country such as South Africa with its complexities and how it affects the livelihoods of people and the impracticality of being able to implement it simply doesn't make it an option, especially not a sustainable option. So we need to have a more balanced perspective. And whether we're at level 5 in South Africa, during level 5, we actually had ongoing community transmission. Unlike other high-income countries, where community transmission actually diminished substantially, in South Africa, we had ongoing community transmission. It was less than before the lockdown, but ongoing community transmission. Now, the success in South Korea, which has been highly successful in terms of what it accomplished, didn't do so with the lockdown, right? They did so by getting an understanding at a level of the populace in terms of what needs to be done, and they did so with the populace actually adhering to the non-pharmaceutical interventions. Right? And the government had a strategy in place which allowed for early detection of infected cases and the tracing of the contacts. So that came as a package, and they were highly successful in terms of being able to contain the spread of the virus in South Korea. And we need to see what sort of a strategy works in South Africa without, like I said earlier, inflicting greater indirect damage due to our response to COVID rather than the direct impact that COVID is going to have. So COVID is a severe disease. It's killing people. It's killing many more people than influenza would kill, probably more than 5 times more people than influenza would have killed in South Africa this year alone. Right? So it's a severe disease. But our response to it needs to be measured, and there needs to be lateral thinking in terms of our approach. We can't be focused on COVID at a detriment of everything else that surrounds us, be it social issues, be it the economy, be it other health issues.
Are you made the point very early on that some aspects of the lockdown we got right and some aspects of the lockdown we got wrong. Now, ultimately, the decision makers would be the president and his command council, then the Minister of Health, who's very much a part of that, then the Ministerial Advisory Committee headed by Professor Karim, and so on, and many other people, right? So, I mean, specifically, in terms of decision making, what decisions have we got right and what decisions have we got wrong?
Yeah, so I think, government obviously needs to speak as to why it embarked on a lockdown. But the main thing that the most positive aspect of the lockdown were twofold. Firstly, it did transiently reduce the rate of transmission of the virus. So although there was ongoing community transmission, that rate of transmission was actually reduced. It's important for the second reason, and that was to allow our healthcare facilities to be better equipped in terms of being able to deal with a surge of cases. So those were two reasons. The third reason, which, and like I mentioned, many people believe that the lockdown was going to eradicate this virus, right? Which means contain the spread of the virus completely. And when we talk of flattening the curve, that's what we're really referring to, being able to flatten that curve and get that virus to sort of almost disappear, as has occurred in New Zealand as an example, or South Korea. That was never going to happen in South Africa. And anyone that believed that was going to be achievable in the South African context, unfortunately, that was a complete miscalculation. Respiratory viruses, the way they transmit, especially in societies such as our own, doesn't lend our type of societies to be able to target that sort of elimination of the virus. And there's very few countries in the world that have been able to achieve it. Unless you're an island nation such as Iceland and New Zealand and able to actually sustain what you've done and lock your borders to the rest of the world until a vaccine becomes available, strategy. So where we came short in South Africa is that there was still an opportunity to basically further slow the rate of spread of the virus by being timiest in our manner of actually identifying infected cases during that period of time. And the lockdown provided us an opportunity of being much more effective in terms of the tracing of the contacts. Because under a lockdown situation, a person will have fewer contacts than in the absence of a lockdown, because you're confined to your house, obviously, most of the time. Unfortunately, in South Africa, we simply didn't have a testing strategy in place when we embarked on the lockdown. And the WHO itself clearly spelled out that a lockdown does not eradicate the virus. A lockdown works in tandem with an effective approach to testing, identification, screening for suspected cases, testing those cases, and actually tracing at least 70 to 80% of their close contacts. Unfortunately, that part of it is something that we've fallen completely short on, not just South Africa, many countries.
So why
simply haven't had
why have we fallen short on that? So let's just get clarity on this one. What was our testing strategy, and what should we have done? I'm just trying to understand exactly what you're saying there.
Yeah, so, well, we didn't have a testing strategy. So the testing strategy at that stage was based on the National Institute for Communicable Disease recommendation that the testing should be limited to individuals that had a travel history, or that were in contact with someone with travel, or that basically were exposed to someone that was known to be infected. That sort of strategy is completely it wasn't appropriate at that point in time for when a lockdown was actually implemented, because it basically didn't allow you to actually go out looking for those individuals that were probably already infected, to actually try to isolate them and trace their contacts and put their contacts into quarantine. So the threshold that was being recommended in terms of who should be tested was an incorrect threshold. That threshold, that bar, should have been much, much lower than what it was actually set in. Anyone that was symptomatic at that point should have been able to access a facility where they could be tested. That result could be given to them within a 12 to 24-hour period. The contacts of that individual could be followed up within a 24-hour period, and those contacts would need to go into quarantine for 14 days. And that is a testing strategy that we should have had in place before we started the lockdown, not in the last week of the lockdown. So unfortunately, that wasn't in place. And there's a number of reasons for that. It's both internal as well as external factors. So there were miscalculations in terms of us not adapting our testing recommendations as soon as we went into a lockdown. But at the same time, the external reasons was the reality that there's a global shortage of testing kits. So despite the NHLS as an example indicating that they were going to be able to test 36,000 samples per day with a 24-hour turnaround in a very near future, they in terms of planning at the NHLS, but there are external factors that are influencing those internal factors in terms of the global shortage of testing kits that are available throughout the world now.
So on a personal level, I mean, I would take it, I mean, and you've been involved in those previous departments that you've just alluded to as in leadership there, but of course you're at WITS now. Do I take it you have the ear of the Minister of Health and then that ministerial advisory committee, or don't you? I mean, do they hear the thoughts that you've just put forward now?
Yeah. I mean, these are not thoughts that I'm sharing for the first time. You probably have heard me mention this previously in public, so it's not something new that I'm saying. And certainly these are the thoughts of the Department of Health all along. But I mean, the Department of Health obviously has got a strategy in place, and they have got, they're following a certain path. And some of it is working, some of it's not working. And I think there's no country in the world that is getting everything right. In fact, some countries are much worse off than South Africa, such as the United States and Brazil, and probably India in the near future. So those countries are much off. So South Africa's government has done things which has basically has a positive effect on the pandemic. Things could have been much worse had they not implemented some of the decisions that they actually decided on. But at the same time, there certainly was and will be opportunities to actually improve. And it just really requires for people to basically allow for different schools of thought to be engaged on, so that we actually can get a more comprehensive perspective in terms of how we need to move forward.
Again, that point, I mean, do you find that your school of thought, which is slightly different, not completely different to, say, the official Minister or Ministry of Health's position, are those schools of thoughts not being heard?
I think all of our schools of thoughts are aligning pretty rapidly now. So we hear the Minister of Health saying that we're going to extremely dark times, which I thought right at the start that we were going to face dark times and we were going to get a rebound immediately after the lockdown. So I think all of our thoughts are pretty much aligning right now, because the reality is upon us that the pandemic in South Africa, this outbreak, is rapidly going out of control. And it's all about what we can now do as a country, as a collective, in terms of trying to mitigate the full consequences of this current wave of the pandemic.
Let's I mean, just recently you were quoted as saying there's possibly 1 million people infected right now. And this is now, 25th of June, because, people may be watching this later and that could change dramatically. So moving forward then, what for you is the high road in terms of numbers? That means if we land up at X number, what would be great considering the problems we've had, and what would be the disaster, the absolute low road?
Yeah, so the disaster relates to the number of people that die, not the number of people that are infected, and it's a disaster. And the current modeling suggests that the number of people that might die in South Africa during this wave of the pandemic is anything between 40,000 and 76,000. I was hoping that it would be spread out over a 2-year period, but I was probably being naive in terms of my belief that South Africans would actually do the right thing in terms of adhering to the non-pharmaceutical interventions, because where we do that, then we can sort of spread that mortality out over a 2-year period rather than much of it happening in a single year. And in fact, over a 2-year period, the number will probably now be greater if those 40 to 70,000 deaths occur in a single year. So that for me is a disaster part of it. In terms of the number game, so again, just to unpack why I come to an estimate of 1 million as an example, rather than 100,000 are being infected. Or yesterday, there were 6,000 cases that were reported. My estimate is that there's closer to at least 30 to 60,000 people that were infected yesterday alone. So what comes to those numbers? It goes back to so our understanding of this virus has evolved tremendously, phenomenally, over a very short period of time. I probably haven't read as many manuscripts in the past 3 months as I have read in the past 25 years, and that is the reality. And what we know is that 1 out of 2 at least, if not 2 out of every 3 people that are infected with the virus will be completely asymptomatic. But they are infected and they can transmit the virus. Right? So already you can take your 6,000 and multiply it by a factor of 3, right? Just on that. Now that 6,000 that were confirmed as being positive, the majority of those 6,000 now are actually individuals that are being hospitalized, right? We're doing less community testing. Now, how does that translate? Of all the people that do become symptomatic, it's roughly only about 20%, 1/5 of them that will end up in hospital. 80%, 90% of them won't actually end up in hospital if they're symptomatic. So if you start doing your maths, basically that's at least an 8 to 10-fold underestimate in terms of the true number of infections. Now, is this completely out of the realm? And the answer, unfortunately, is not. If you look, so at some stage, we're going to be able to do what we call seroepidemiology studies in South Africa, which is sort of a blood test which tells you whether someone has been infected or not in the past. It doesn't tell you if someone is infectious at this point in time. When they did it in New York City, as an example, 1/4 of the population in New York City were shown to have been infected. 1/4, 25%. In other places where they've done it, they've gone to 10%, 15%. South Africa, with a population of 59 million, if we only get 10% of our population that are infected with this wave, I'll be highly satisfied that we've done a great job. But that 10% is 6 million people. Okay, and I think we're probably going to end up with 20% being infected with this particular wave, and that 20% is 12 million people, right? And right now, we're very nearing the peak of this pandemic. So 1 million, for me, is probably a conservative estimate in terms of the true number of people that have already been infected in the country.
And when you talk about a peak, so how do you, when we say we are nearing the peak, how do you determine what is a peak? I mean, I'm hoping 100,000 is a peak. Clearly, you may be hoping that the 1 million is the peak. How do we determine, well, that's a peak? Because we're speaking ahead of time as opposed to in the past tense.
Yeah, so we only know that the peak has arrived is when it starts subsiding. And there isn't putting any sort of a timeline to it. How long the peak lasts, again, depends on the behavior of South Africans in terms of the non-pharmaceutical intervention. So as an example right now, and the best measure in terms of determining whether we're peaking or not is not the number of cases that are being tested randomly, but rather the number of individuals that are being hospitalized. And once we start seeing a change in terms of that curve, the trajectory of that curve, it's going to plateau off at a peak level for about 2 to 3 weeks, maybe 4 to 5 weeks, as an example in Spain. But once that starts coming down, and then once the number of daily reported cases starts coming down, then we know that we've basically passed the peak. So then we're on the waning phase of this particular wave of the outbreak. So there's no predicting when we're going to be at a peak and how long we're going to be at that peak, but the measures that we use to establish as to whether we've peaked or not is that once we start seeing a decline in terms of number of admissions, once we start seeing a decline in terms of number of people that are dying on a daily basis or a weekly basis, then we can say that we've already now reached our peak and now we're on our way down.
Help me understand this.
So there isn't
Okay, help me understand this. In the absence of a vaccine, right? If, say, 20 million people over a year or two are infected, why would it then not be 60 million? So why would it just stop at that point?
In terms of, like I said, firstly, what happened in high-income countries is that when there's a huge amount of people dying, people take these non-pharmaceutical interventions much more seriously, right? And then they start adhering to these non-pharmaceutical interventions. That slows the rate of transmission of the virus, and that is actually contributing to that. United States, in many states in the United States, that they've started to open up, they've had another flare-up in terms of outbreaks. Right? And that is because people are not adhering again. They're becoming complacent, thinking that this wave has passed, the virus has disappeared, and all it takes is for people not to be adherent to the non-pharmaceutical interventions, and you're going to get a second wave. And that is pretty much predictable until at least about 2/3 of the population develop long-lasting immunity against this virus. Now, that magic figure of 2/3 for this virus is really sort of the percentage of the population that needs to develop immunity, at which point you're able to, in a completely naive population where no one has been exposed to the virus and no one has got immunity. As for this virus, as an example, every one person that's infected, they would infect 2 to 3 other people. And those 2 to 3 other people would then infect another 2 to 3 other people over the next 2 to 3 days. And over 10 cycles, that goes into the thousands. And over 20 cycles, that goes into the hundreds of thousands. So it's a huge number. But eventually what happens with this sort of a number, what we call the effective reproductive rate, is that it goes from that 2.5, and as a greater percentage of the population develop immunity, that effective reproductive rate starts decreasing because there's more people in the pool now that are immune. So even if they get infected, they're not going to transmit on to someone else. So we want that effective reproductive rate to be less than 1. But to get that effective reproductive rate to less than 1 for this sort of a virus, with this reproductive rate, you need to get about 2/3 of the population develop immunity. That 2/3 of the population could develop immunity through natural infection. The problem with natural infection at this point is we're not too sure how long that immunity persists. We want the immunity to persist for a long time. That's the reason why the vaccine is really important, because the vaccines are much more predictable in terms of the immunity it induces and the duration of immunity that's induced.
Well, so much that's come out of it. Just 2 things before we wrap up then. Your clarity on the issue of being infected by surfaces. I mean, I've heard mixed messaging from nobody higher than the WHO representatives themselves. What is the position now in terms of your understanding?
Yeah, so I think, again, that is a field that has evolved literally over the past few weeks. And previously, our belief was that the main source of transmission was through fomite spread, which basically means you touch contaminated surfaces, which are then you basically wipe your eyes, wipe your nose, wipe your mouth. And that's why we were emphasizing hand hygiene, hand hygiene, hand hygiene. Over the past month, there's been a number of studies which have now shown that, in fact, probably the more common mode of infection and of being infected is either through direct transmission, which is when people are sort of within a 1.5 meter distance of each other. If the one person is infected, knowingly or unknowingly, they would basically release these contaminated droplets, and those contaminated droplets would land on the other person's mucous surfaces, in the mouth, in the nose, in the microscopic droplets which you can't even see. But they can land on your mucous surfaces and you would become infected. And that's the reason why we emphasize not going into mass gatherings. That's the reason why we emphasize the importance of physical distancing. That's the reason we emphasize the need for use of surgical face masks. It's sort of to prevent that transmission. The other component to it is that when people speak, and you don't need to be coughing to be transmitting this virus. You can just speak, even if just breathing, you can still release this sort of microscopic contaminated droplets. The other concern is that, especially in closed spaces where there's poor ventilation, is that these microparticles can remain airborne for about 5 to 10 minutes. So someone that walks into that environment that basically breathes in those microparticles might actually become infected as well. But I think that's a less common mode of acquisition. The most common mode of acquisition is this direct inoculation between people because they're not exercising physical distancing, because they're not wearing the non-surgical face mask. And in a hospital environment, they would also need to sort of put a visor on to prevent these droplets passing into their eyes. and consequently
Well, I'll
becoming
tell you what,
infected.
to end, we certainly hope that the vaccine is on track and it comes sooner rather than later. We all want to be alive and sharing good experiences with not just you and I, but certainly with the rest of our families, right? Just the last thing then, Professor Madhi, what message now would you give to President Ramaphosa? So I know you're not on social media, but if you had the 1 minute tweet, what's your one message to the president?
I think he's done as much as he can. The message really is that we need to get South Africans to understand, to be better educated about what this virus is, how it transmits, and why, even if we're not at risk of developing severe disease, why it's essential that we all work as a collective to slow the rate of transmission of this virus. Government, at the end of the day, in a sense, not just South Africa, but all Africa, sub-Saharan African countries, all low middle-income countries, they've become a victim of their own underinvestment in terms of resilient healthcare systems. And that is a message that we need to take moving forward, that you do not underinvest in healthcare, and then when you face with a crisis, the cost of dealing with a crisis far exceeds what you could have invested upfront and avoided the crisis that you had.
And certainly that's where we are right now. Let's leave it at that, Professor Shabir Madhi, the Vice Professor of Vaccinology. Appreciate your time and thanks for effectively, setting an agenda on what happens next around this rather complex issue around COVID-19, this pandemic that literally is just that. It's impacted around the globe. Thank you.